Emicizumab prophylaxis in patients with hemophilia, a weak dose inhibitor. Definition: Emicizumab is a bispecific monoclonal antibody that binds activity factor IX and factor X to replace certain fusion of mission-activated factor VIII. Therapy restoring hemostasis in a phase 3 multicenter trial, with investigation in used as prophylaxis in persons with hemophilia, a without factor VIII inhibitor.
Episode 2. Introducing inhibitors. Welcome back. In episode 1 we met team clotting and learned what happens when the team is not working as it should. People with hemophilia A either lack factor VIII or have factor VIII that does not function properly. Without factor VIII, a clot cannot form properly, and so bleeding continues. To overcome this, a replacement factor VIII treatment can be given. For team clotting, this is like asking a high jumper to take the place of our runner, so the competition continues and a clot is formed. However, antibodies, known as inhibitors, can form against replacement factor VIII treatments. These inhibitors recognize the replacement factor VIII as foreign and stop it from working. Inhibitors are like the competition officials who declare the high jumper's attempt invalid, interrupting the team's event. By interrupting the replacement factor VIII jump, the team competition stops. This means factor X does not get the baton, fibrin cannot compete, and the crowd do not gather. Without the protein fibrin to bring together the platelets, a clot cannot form properly, and so bleeding continues. If inhibitors form to replacement factor VIII, other treatments can be taken to restore blood clotting. However, they vary in response and are associated with a high treatment burden. This is why the development of inhibitors against factor VIII replacement therapy is one of the greatest challenges in the treatment of hemophilia A today, putting patients at high risk for life-threatening bleeds and repeated bleeds that may cause long-term joint damage. New approaches are in development to overcome the issue of inhibitors. We'll tell you more about them and what they could mean for team clotting in the next episode, so stay tuned for episode 3.
Application in nursing with randomly assisting in a 2-to-1 ratio participation 11 years of age or older worth of big receiving episodic tetrang with factor VIII to receive a subcutaneous maintenance dose of emicizumab of 1.5 mg per kilogram of body weight per wave group A or 3 mg per kilogram every 2 wave group B or no prophylaxis group C. Their primary endpoint was their difference in rate of track blend group A versus group C and group B versus group C. Participation would have big receiver factor VIII prophylaxis receiving emicizumab at a maintenance dose of 1.5 mg per kilogram per week. Group D intra-individual comparison will be performed in those who have participation in a monitor everything study.
People with hemophilia A lack factor VIII and require prophylactic or episodic intravenous infusions of factor VIII, typically 2 or more times per week, to prevent bleeding complications. About 1/3 develop antibodies or inhibitors against factor VIII, and despite regular factor VIII infusions, bleeding complications can occur. The Haven 3 trial was a phase 3 multicenter study to evaluate a novel prophylactic treatment, subcutaneous emicizumab, a monoclonal antibody that bridges activated factor IX and factor X to replace the function of missing factor VIII. The trial included 152 people who were 12 or older with hemophilia A without factor VIII inhibitors. Patients previously using episodic factor VIII were randomized to receive emicizumab maintenance once a week, emicizumab maintenance once every 2 weeks, or placebo. Patients previously using prophylactic factor VIII were switched to weekly emicizumab maintenance. Treatment continued for up to 50 weeks. For patients previously using episodic factor VIII, the annualized bleeding rate was 38.2 with placebo, as compared with 1.5 with the weekly emicizumab dose, and 1.3 with the every 2 weeks emicizumab dose, a reduction of more than 96% with both emicizumab doses. For patients previously using prophylactic factor VIII, the annualized bleeding rate was reduced from 4.8 with factor VIII to 1.5 with emicizumab maintenance, a 68% reduction. Over half of patients on emicizumab had no bleeding episodes. The most frequent adverse event was a low-grade injection site reaction. There were no thrombotic events, anti-drug antibodies, or factor VIII inhibitors. The authors conclude that for patients with hemophilia A without inhibitors, subcutaneous emicizumab prophylaxis once weekly or every 2 weeks significantly reduced the bleeding rate, and weekly emicizumab was associated with significantly lower bleeding rates than factor VIII prophylaxis. Full trial results are available at nejm.org.
Pros and cons. Pros. Emicizumab is effective in patients with hemophilia A and TUSI with are prophylaxis improving. Even the blending had previous and in terms of safety. There has been no complication with emicizumab association with factor VII has been used hemopathologic point of cons. On interest people with severe hemophilia A may develop inhibitor of factor VIII replacement therapies with matrix replacement therapy oxalatic and predisposition patients to life-threatening or recurrent blended attacks can cause long-term joint damage.
So let's segue into your past treatment was using factor as you needed it, or what we call on-demand or episodically.
Right.
And we discussed doing prophylaxis, but then this opportunity to participate in a clinical trial with this drug called emicizumab. And I'll just give you a little bit of background on what emicizumab is. It's not factor, it's what we call a non-factor therapy, and it was developed, it's a therapeutic monoclonal antibody, and it's called a bispecific monoclonal antibody. That means it binds to activated factor IX and factor X, and it mediates the activation of factor X. And so the role of factor VIII is to bind activated factor IX and X, bring them together, which activates factor X, and that goes on to activate the rest of the clotting cascade. And in hemophilia patients, you're missing factor VIII. So this bispecific antibody takes on this role and will bridge the binding of IX and X together, and thus it activates X, and then it restores hemostasis.
Right. So it's like a bunch of dominoes.
Exactly.
And factor VIII is one of the dominoes that's missing.
Right, and it's a very
and the new
important
drug
domino.
tricks the next two dominoes, saying, "Hey, Factor VIII already happened. Go, keep doing your job.
Right, and so that's kind of the mechanism of action, and we asked you to participate in using this, and so it was this drug was used for both patients with inhibitors and without inhibitors in hemophilia A. So what was your experience with emicizumab when I asked you to do it?
Oh, I thought the potential was amazing, and I mean, the only thing I can really say about it is it's life-changing. It has been life-changing, so I've been on it for a year and a half or something like that now, right? I have not done a single Factor VIII infusion in that time, and this infusion is so super convenient also. Like I do, my protocol is like one shot every 2 weeks, and it's like a diabetic shot. It goes right in the fat, not in the vein, so it's really easy to do. I don't need to worry about missing veins, and it's like it's like 2 cc's. It's very, very little, and then all of a sudden I'm good for the next few weeks, right? So that's been just a huge, huge life changer. So now, like when I feel a little bit of pain, when I was a kid and I would procrastinate and say, oh, it'll go away, and never did. Now I'm like, okay, I have a little pain. It'll go away, and wait, it does go away. So I'm like, oh, this is new. Don't know how this is. So it's been a complete life changer and game changer, I think.
So as the clinical trial draws to an end, what do you think? Would you consider continuing on this medication, or?
I definitely cannot consider going back. So yeah, I don't.
So moving forward, you're going to try to continue on this medication.
I don't even know why I would possibly ever go back.
So data on the study was published, and I don't know if you actually have seen the data. I haven't reviewed it with you. And so you were in there were 3 arms to this study. One was continuing on your on-demand therapy using Factor as you need it, and one arm was what you were on, which was giving yourself the shot every other week. And the third arm was actually doing shots once a week with the emicizumab. And so they found actually that compared to on-demand, there was a 96% decrease in the annualized bleed rate. So they measured the number of bleeds you had per year, and they looked at the annualized bleed rate. There's a 96% reduction in the once-a-week shot, and a 97% reduction in the bleed rate in the every 2-week arm.
So 2 weeks is more effective, even by a little?
That's not statistically significant.
Right.
Let's just say over 95%. Yeah, it's just as good. And so there was another study which they called Haven 4. Yours is Haven 3. And they actually looked at this drug being used once a month. So that's another consideration. And very similarly, the annualized bleed rates compared to on-demand were much improved.
Wow.
Issued application in Ecuador. Test of egg until pharmacokinetic of emicizumab was evolution in a pharmacokinetic analytics population that including 5 infants 1 month to years children 111 years of fighting adolescent 11 to 18 years with hemophilia A had no affected in pharmacokinetic of emicizumab in pediatric patients.
The major complications associated with emicizumab treatment was the development of thrombotic episodes as well as TMA or thrombotic microangiopathy. These were unexpected complications, especially the TMA in patients who were treated with emicizumab. It was noted only in those patients who received APCCs in large doses over a prolonged period of time. So the thought process is that there's potentially significant increase in thrombin generation associated with the background emicizumab and the addition of activated PCCs, and prolonged treatment in these situations resulted in excessive thrombin generation, which resulted in TMAs as well as thrombotic episodes. There were also some episodes which were questioned as being thrombotic episodes but were treated as bleeds, and so potentially led to worsening of the thrombin generation and worsening of the thrombosis. So TMA and thrombosis are the major complications that are associated with emicizumab administration. Since both TMAs as well as thrombotic episodes were seen in patients who received excessive or high doses of APCCs for prolonged periods of time, specifically greater than 100 units per kg per day, and typically for more than 24 hours, the black box warning included that we should not use doses that exceed 100 units per kg per day and try to restrict the use to less than 24 hours. If higher doses are required, or if prolonged use of APCCs are required in the setting of a patient who's on emicizumab, it is recommended that patients be followed very closely by the hematologist and potentially even consider admission to the hospital so that they can be monitored for the development of TMA as well as thrombosis. The combination of emicizumab and APCCs may be required in some patients. It is well recognized that there are patients who do not necessarily respond to recombinant factor 7A, but it is still recommended that we try recombinant factor 7A as the first drug of choice for management of breakthrough bleedings. If this does not work in a patient, or if the bleed is severe or significant such that the recombinant 7A is not working, then we should consider the use of APCCs, which should be managed by a hematologist who's well versed with the complications associated in this situation. The development of TMA and thrombotic episodes was seen in patients who used high doses of APCCs and with emicizumab. So the first, if these complications were to occur, the first thing to do, of course, is not to give the next dose of emicizumab. But in addition to that, most of these are managed symptomatically with supportive care. TMAs especially might require hydration, monitoring the hemolysis that is being observed in these patients. They may require inpatient hydration and monitoring for worsening of renal failure or development of CNS pathology. In terms of thrombotic episodes, again, they may require anticoagulant therapy, but so far I do not believe that any of these patients have been treated with anticoagulation while receiving emicizumab. Supportive care has been found to be effective, but that will also depend on the location of the thrombotic episode of the thrombosis, and this would need to be determined on a case-by-case basis. Breakthrough bleeding in the setting of emicizumab should be handled individually on a patient-by-patient basis as well as on a bleed-by-bleed basis. Severe bleeding should be treated like it was treated before, in that you should replace immediately with clotting factor concentrates, and in the non-inhibitor population, they would be treated with doses that they would use previously. In the inhibitor population, on the other hand, we should be careful about the doses we use, and if you're using an APCC, our doses should not exceed 100 units per kg per day. In the non-inhibitor population, this is not as much of a concern because the factor 8 would replace the emicizumab as soon as it is infused. So we do not anticipate that there would be any complications related to the concomitant use of recombinant factor 8 with the emicizumab. The most of these complications would only occur in patients who are using APCCs in conjunction with emicizumab. Minor bleeding episodes, on the other hand, may not require any treatment in these patients because emicizumab may provide effective clotting potential in these patients. So small bleeds may be monitored without any treatment and treated only if any worsening of symptoms is noted.
Conclusion: Emicizumab prophylaxis administration subcutaneous on weekly or every 2 weeks left to a significant lower blended rather than no prophylaxis among persons with hemophilia A without inhibitor. More than half participation were received prophylaxis have no theatric blended event in the individual comparison. Emicizumab therapy led to 8 signification lower blender rather than previous factor 8 prophylaxis.
The National Hemophilia Foundation, or NHF, recently issued a new recommendation on inhibitor testing for patients with hemophilia A and B. I'm Shelby calling in with your latest health news. According to the NHF, hemophilia patients should be tested for inhibitors at least once per year to avoid serious bleeding complications. High-risk patients may need to be tested even more frequently. Hemophilia is a rare genetic disorder in which the blood does not clot properly because it lacks sufficient blood clotting proteins. The main treatment for hemophilia is called a clotting factor, which is injected into the patient's veins to replace the missing proteins. Approximately 15 to 20% of hemophilia patients will develop an antibody called an inhibitor to the medication used to treat or prevent bleeding, according to the CDC. The NHF recommends that patients ask their doctors about the risk of inhibitors, how often they should be tested, and what they can do to avoid developing one.